and then with continued progression can then lead to cirrhosis of the liver. So if you look at the spectrum of NAFLD, you have fatty liver on the one end, you have NASH on the other end, and then as far as the end organ damage, you have something called NASH-induced cirrhosis. So prevalence, as you may imagine, the prevalence of non-alcoholic fatty liver disease is quite high in the United States. Studies have put it between 10 and 46%, depending on the population, depending on the region, depending on ethnicity. 3 to 5% of these patients will likely have NASH, and then 20% of these patients who do have the NASH will progress to cirrhosis of the liver. Interestingly enough, if you look at just prevalence, between 1988 and 1994, NAFLD had a prevalence of 5.5% in the US. Between 1999 and 2004, it doubled to 10%. And currently, it sits at almost 15% prevalence in the United States. That essentially accounts for 75% of all chronic liver disease in the United States. Causes. The main cause for non-alcoholic fatty liver disease is a condition called metabolic syndrome. Metabolic syndrome has many other names, including syndrome X, and it has 4 components. Basically, a condition called insulin resistance, which most of us know as either prediabetes or diabetes, obesity, elevated lipids or cholesterol profile, and hypertension. You do not have to have all 4 of these components. Any one of these components can be a contributor to non-alcoholic fatty liver. As far as obesity, you can see that 2/3 of these patients will have non-alcoholic fatty liver, and 20% of obese patients will likely have NASH on initial presentation. Approximately 88% of patients who have NASH on biopsy are going to meet conditions, are going to have all four components of metabolic syndrome. Of course, metabolic syndrome is not the only cause. There are others. Cardiovascular disease. I mean, if you look at what metabolic syndrome is, prediabetes, obesity, elevated cholesterol, hypertension, all of those are risk factors for cardiovascular disease as well. So it's not surprising that cardiovascular disease also is a risk factor for non-alcoholic fatty liver. OSA stands for obstructive sleep apnea. Interestingly enough, patients with sleep apnea have been shown that that is a risk factor. Again, everything kind of comes back to, because the majority of patients who have obstructive sleep apnea are also obese. So all of these are fairly intertwined. Interestingly enough, there's been some studies that have shown that patients who've had prior gallbladder resection, that is a independent risk factor for non-alcoholic fatty liver disease. Don't quite have an understanding of why that is the case, but that is a risk factor. And certainly patients who have underlying hypothyroid or low thyroid function. The most supported theory as to why people develop non-alcoholic fatty liver disease is basically insulin resistance. Once insulin resistance occurs, that's when you start to see fatty buildup in the liver. Now, there are multiple other theories that have also stated that fatty liver, buildup of the fat in the liver is the first step, that there may be a second hit that occurs that leads to further progression from just straight fatty liver to inflammation to fibrosis to cirrhosis. And again, those are, as far as that second hit, there are multiple thoughts on that, but there's not any one solid mechanism that has been proposed yet. The majority of the patients who usually come to attention, really, they're asymptomatic. They are usually found because they have some mildly abnormal liver tests when they go in for their routine laboratory work, or they have abdominal imaging done for some other reason and are noted to have either enlargement of the liver or steatosis or fatty buildup in the liver. Those who have symptoms, usually the symptoms are fairly vague. The vast majority will complain of fatigue. And if they do have enlargement of the liver, they may complain of some vague abdominal discomfort in the right upper side of the abdomen. So, diagnosis. Of course, you have to demonstrate that there's fatty liver. And you can demonstrate that either by imaging or by biopsy. You need to exclude alcohol, especially heavy alcohol intake. So what is considered heavy alcohol intake? Currently, the guidelines state that greater than 21 alcoholic drinks per week in men, or greater than 14 per week in women. You have to exclude other causes of steatosis. There are other conditions that can lead to fatty buildup. Patients who are on long-term steroids can get fatty buildup of the liver. Patients who are on prolonged intravenous nutrition can get fatty liver. There are certain medications, certain cardiac medications, one being amiodarone, which is used for heart rhythm management. And then there also are certain seizure medications, which can also lead to fatty buildup of the liver. And of course, you want to rule out other liver diseases, commonly, of course, alcohol being one, hepatitis C being another. In the past, liver biopsy was considered the gold standard, and it still is the gold standard as far as making a definitive diagnosis. Nowadays, we have non-invasive tests which have made liver biopsy no longer the definitive. Now liver biopsies tend to be focused in patients who you think have who are more towards the NASH or possibly even towards cirrhosis. Those patients typically end up getting liver biopsies, and not so much patients who are more on the non-alcoholic fatty liver side. And part of the reason why is because we have non-invasive tests now. There are some blood tests that are available. There are 2 proprietary tests that are now available on the market, one being FibroSure, which uses multiple blood tests parameters and then puts it in an algorithm, and then we'll give you a score. We'll give you a steatosis score, we'll give you a fibrosis score, and then we'll give you a NASH score. And then we will utilize those numbers to determine, again, if patients are felt to be at a high risk or they have a high score for NASH, then those are the patients we may consider doing a liver biopsy on. There are also 2 additional imaging studies now that are available to assess if patients have more advanced disease. One is called FibroScan, and that is basically it's an ultrasound probe that just shoots ultrasonic waves into the liver, and it measures how stiff the liver is. And again, using an algorithm is able to give you a score in terms of how much fibrosis is present. And there's also an MRI elastography, which works by a similar mechanism, but uses an MRI instead. So both of those tests are in use and really have supplanted liver biopsies now. Management, of course, those who are consuming alcohol, not heavily, but still consuming alcohol, we would ask that they abstain from alcohol. Of course, you want to modify the risk factors for cardiovascular disease, as well as the metabolic syndrome. Want to work on controlling blood pressure, work on decreasing cholesterol, tighter control of blood sugars in those who are diabetic. Weight loss. Weight loss really is, as of right now, the mainstay of treatment for non-alcoholic fatty liver disease. If patients just have non-alcoholic fatty liver, the recommendation is that they need to lose at least 5 to 7% of their body weight. If they have on the more advanced side where they have NASH, then the recommendations are 7 to 10% of their total body weight. And even some of the newer studies are suggesting that it probably needs to be more towards 12% or greater as far as weight loss of their total body weight. And of course, that involves diet, exercise, things that obviously that's part of the reason why we're all together. We want to focus on managing our health and disease states by eating well, eating healthy, exercising, and that's really crucial. Of course, not everyone is going to be able to achieve the targets that we put down for them. Those who cannot, we have certainly advised bariatric surgery in some of these patients, and I don't use it very often, and it's not something that we frequently use often, but we will sometimes look at anti-obesity medications as well. It's difficult. It's difficult because a lot of times these medications are they're expensive. Many times they're not covered by insurance, and of course sometimes these medications are controlled substances, and a lot of providers tend to shy away from those. As far as managing fatty liver itself, I mean, of course, these are things that we talk about of how to improve it. But if someone has fatty liver, what type of therapies do we have at present to try to improve what is going on in the liver? Not much at present. There are numerous studies that are out looking at ways to reduce the fibrosis that is being laid down in the liver. Currently, it's all in early investigation phases. There are some drugs that are used. Vitamin E is one. Vitamin E being an antioxidant, has been utilized and shown some efficacy in those patients who have fatty liver without diabetes. If they're diabetic, then vitamin E is not recommended. In those who have fatty liver and diabetes, 2 drugs have been used. One is metformin, and the other one is pioglitazone. Both of which metformin has not really shown significant efficacy. Pioglitazone has shown some efficacy. It has shown that it can reduce inflammation in the liver. But again, these are still in their infancy. The target will be, and this is where, as we talked about, the prevalence of this disease. Right now, pharmaceutical companies are working overtime to try to find new drugs to somehow work on minimizing that fibrosis. That's where the big target is right now in terms of managing this. I know it was fast. I'm a very fast talker. I'm sorry. But let's talk about questions people have, or what other things
Sure.
we could.
Well, thank you, Dr. Bouchon. That was a very good summary of a very big problem in this country. I guess Well, people are thinking of questions. If you have questions, please put them in the chat or just raise your hand and I'll call on you here. The first question I have is, if somebody is worried that they might have fatty liver or non-alcoholic steatohepatitis, what would you recommend they ask their primary care doctor to test them for initially? Would a set of liver function tests be adequate, or would they need to, ask for one of those more advanced proprietary lab tests, or what would you recommend?
The usually, mainly the initial test that is done is an abdominal ultrasound.
Okay.
An abdominal ultrasound will at least give you data in terms of, do you see fatty buildup in the liver? Do you see enlargement of the liver? As we talked about, the majority of these, not the majority, but a significant number of these patients will be asymptomatic and will have normal liver function, normal liver tests. But again, I think this is where you're starting to see, because of the prevalence of this, that especially those patients who do have the metabolic syndrome parameters or components that are met, I think right now there is no guidelines that recommend any particular screening for non-alcoholic fatty liver, but that's coming. Okay. I think just like we are doing ultrasounds for aortic aneurysm screening, I think you're going to see in the future that an abdominal ultrasound for non-alcoholic fatty liver screening.
Well, and it may be that ultrasound could prove to be the key factor for somebody who's kind of on the fence about making some diet and exercise lifestyle changes in their life. If they found out that they actually had a high FibroSure score or whatever it is,
sure.
They may be more inclined to make some changes. We have a question from Chris Anderson about what is the age that this might typically happen?
So typically, non-alcoholic fatty liver is diagnosed in patients in their 40s and 50s.
Okay, and Dr. DeGraff has a question. I may have missed this. Are there any genetic predispositions for fatty liver?
No.
Okay.
Not that we know of.
So Kiana, there it is. Linda Johnson's asking, her niece is in need of kidney dialysis, but her doctor's afraid that she is not strong enough to endure it. Would you have an opinion on this? Doctor says she'll die without it.
For kidney dialysis?
Yeah, I guess it's not my area of expertise or yours, but
if they're in, I mean, I would imagine if they're in kidney failure and they need dialysis, then it is essential. It's a life threat. Otherwise,
yeah, not being strong enough to endure it is a problem. Yeah. I've had fatty liver findings in kids. How do you manage in kids? Is it diet only? This
exactly.
Is one of our healthcare providers is asking.
Yes, exactly, and that's a good point, because just because we're talking about adults here, but obesity has obviously become a major issue in our pediatric population as well, and so yes, we're seeing fatty liver in that population, and of course, being that they're young, that's where we need to target. We need to target healthy lifestyle, healthy eating, exercise, weight loss.
Good, Kiana, I see your comment there, and it reminds me of the joke. If I had more time, I'd throw the cartoon up on the screen, but I'm sure all of you have seen me use it in a health talk, of the patient saying to the doctor, "Diabetes runs in my family." And the doctor's response is, "No, nobody runs in your family." And that's the problem. But I know that's not the DeGraff family's problem. I saw pictures of them all out at the marathon that just happened yesterday. I think they ran either the 5K or the half. I'm not quite sure. Maybe Sammy was running the half marathon or something. Of course, Pastor Chris was running the full marathon because he's never going to have diabetes ever.
That's great.
So going back to the idea of non-alcoholic steatohepatitis, could you talk us through what cirrhosis looks like? I think most of the people on this call probably don't drink any alcohol. And we're not really, if we haven't drunk alcohol in our families, or we don't really have relatives that are drinking heavily, we're probably not that familiar with what cirrhosis actually looks like. And so non-alcoholic steatohepatitis can also lead to cirrhosis through this different pathway that you're talking about. What does that actually look like as far as treatment options and end-stage cirrhosis, things of that nature?
So once, of course, you have inflammation. Inflammation then leads to fibrosis, and then fibrosis leads to scar tissue being laid down in the liver. Once you get to a point of no return, there's enough scar tissue that lays down, and the liver starts to become very fibrotic, hard, starts to shrink. Then that at that point you start to develop, and that affects the function of the liver. That becomes cirrhosis. And then when you reach cirrhosis, that is the point of no return. It cannot be reversed at this point. The liver has tremendous regenerative capacity up to a certain point. But once you reach to the point of cirrhosis, that means now you have liver dysfunction. So the liver's job is multifold. Obviously, liver is your filter of the body, if you will. The liver's job also is to make sure that you always have enough sugar going through your bloodstream, even when you're fasting. The liver's job is to make sure that you have enough clotting factors so that when you do get a cut or anything, the body has the ability to clot. So there are multiple things that are involved with that. But once you get to the point of cirrhosis, several things start to happen. Several complications begin. One of which is you start to retain fluid. Because one of the other major components that the liver is to do is that it produces the blood proteins, or the proteins that are in your bloodstream. And when those proteins start to be deficient, then fluid from your cell or from your blood vessels starts to leak out into your soft tissues. So you get fluid overload, whether that's in your legs, and then you can also get fluid overload in your abdomen. So that's one complication. Another complication, obviously, is that you are at increased risk of bleeding from your GI tract. As the liver becomes smaller and fibrotic, as I had mentioned before, the liver is kind of the filter of the body. So that means the liver has a tremendous amount of blood supply. There's a large caliber vessels that are coursing through your liver as they bring blood and take blood away from the liver. And as the liver shrinks, these blood vessels get compressed. And like with any plumbing, if you start to get a clog, if you will, there's back pressure. And when you have back pressure, it has to be relieved somewhere. And so the GI tract is a common place where where you get these veins that will start to balloon or dilate out. And of course, as they balloon and dilate out, there's a propensity or risk that they can burst, which then cause massive bleeding. Third, again, being that the liver is the filter of the body, if it is not able to filter, then you have buildup of toxins in your bloodstream, which then in turn can affect your level of mentation. You can start to have issues where you become confused to the point where you can become completely comatose. And then lastly, one of the other complications of having cirrhosis of the liver is once you have cirrhosis, then that increases your risk significantly of developing cancer of the liver, which is called hepatocellular carcinoma. So that is what cirrhosis those are some of the complications of cirrhosis as that disease progresses. Of course, you try to manage the complications the best that you can, medications, trying to make sure you keep the volume, fluid overload under control. You try to make sure that you keep these patients from potentially bleeding, follow them closely and assess them for any potential signs of early cancer. And then, of course, treatment for cirrhosis is liver transplant. In the U.S. now, the number one reason for liver transplant is NASH-induced cirrhosis. NASH-induced cirrhosis has overtaken alcoholic cirrhosis and hepatitis C-induced cirrhosis within the last 20, 25 years. It is now the #1 reason for transplant, for liver transplant.
They'd probably move up the list as well, because obviously someone with alcoholic cirrhosis, they have to be off the alcohol for some number of months before
Correct.
they're considered for transplant. So
Correct.
probably has something to do with it as well. Well, that just kind of, I don't want to say it strikes fear, but this kind of is a silent sort of disease process that we may not be aware of, but it's certainly completely lifestyle related, and so somewhat predictable at least. And so those individuals who are at risk for it, like you said, there probably needs to be some sort of screening and some sort of awareness by those individuals who are especially at risk, that they need to talk with their physician about this. And of course, there's a lot of other related lifestyle issues that you listed under metabolic syndrome, and any one of those is probably reason enough to try to make some changes. But maybe this one would push over the edge. Looked like Chris started sharing a screen there for a second. We were seeing what he's getting ready to order for dinner or something.
Yeah.
I hope it's something healthy, Chris. There, he's off celebrating a birthday there at the moment. So I did want to take this opportunity to make a shameless plug for the Best Way program that will be starting in January again. Probably late January, we'll start our next Best Way weight loss program. And likely one more year it will be online, so it's very convenient, although not nearly as much fun as when we can all get together in one place. But the church building that I showed you is not likely to be finished by January, but it'll probably be finished so we can do our diabetes program in person again this year. Again, for those of you who came on just a little bit late, I was just showing this picture here of what's going on our church property. And there's our health center right over there. So we're looking forward to that being finished. Let me take this. Are there any other questions before I close here? I'll stop sharing because I did want to share one other thing with you here in a second. Are there any questions? Anyone want to raise your hand or put something in the chat there? I just got a text message from somebody on this call saying they want some Best Way invites. Great idea, Emily. We want to get some of those out, but we also need to be actually pick the exact dates. Linda Johnson asks, what should we be watching for on our blood tests?
Again, if you want to make sure that your cholesterol is well controlled, if you're diabetic, you want to make sure that you're well controlled, and the way they will measure that is with something called the hemoglobin A1C. Ideally, you would want that as close to 6 or below, and of course, making sure that if you have high blood pressure, that's well controlled. Eating healthy, exercise. As far as your liver tests, you will look. When you get your lab work back, you will see several different tests. The two that you want to look at for your liver are two tests called AST and ALT. If those are elevated, then likely your physician will want to evaluate that further.
Good. Kiana has another question. Are type 1 diabetics as much at risk as type 2, or is there any difference?
Interestingly enough, they both are, but type 2 diabetics seem to have more prevalence or for non-alcoholic fatty liver as opposed to type 1.
That makes sense based on the pathophysiology that you
Correct.
described there, where the insulin resistance is one of the main factors there. It was interesting how much you mentioned inflammation, and at the risk of being grossly oversimplistic, I know all of us have probably heard about an anti-inflammatory diet, which is pretty much just a healthy plant-based diet. Mm-hmm. And I know that's a gross oversimplification, but it's also at least partly true that what we eat does have an effect on the total amount of inflammation running around our body. And a lot of the healthy foods that we would recommend do have a lot of antioxidants within them. So, any other final questions here? Well, let me make another shameless plug. My wife has redone our website yet again. So DWTDHickson.com. You can, of course, look for all the different programs on here. And if you follow that link, it'll take you to southbaysda.org and you can get more information about some of these other programs. I would point out that some of these programs are also archived. You can go back and watch videos of some of the other programs that we've done. I will also point out that there is a link here for recipes. And if you are wondering what you should cook over Thanksgiving, which of course is coming right up here, or Christmas, there are some great menus there. There's some recipes by category, and they're all, of course, alphabetized as well. So I just am amazed at the number of recipes that are on here. But all of these recipes, I believe, we have served at Dinner with the Doctor over the last 5 years. So as you kind of look over the number of recipes, it just kind of gives you an idea of how many programs we've done. And it's kind of fun to think back over that, see how many of these recipes you recognize. So we did a lot of Indian food, and we did a Turkish meal. I remember that. We did a Korean meal as well. I remember that Susan Pratt and her parents helped us with that. So there's lots and lots and lots of wonderful, wonderful recipes here that I would encourage all of you to try. And of course, there's some other resources here. Some of you from Dinner with the Doctor have done some meals at your homes. I know that Dan and Nancy particularly did some lockdown meals on their back porch with their neighbors. And that's a lot of fun as well. So with that, I want to, yes, Linda, we recorded this, and I'm not sure when it will be posted, but we do try to post some of these recipes. That's a great question. Well, with that, why don't we bow our heads for prayer? And I just thank all of you for coming, and I especially want to thank you, Dr. Bouchon, for spending your afternoon with us and giving us some expert advice on non-alcoholic fatty liver disease, something that we all need to be aware of, and something that we probably need to ask our primary care doctors about, and make sure that we are optimally managing our health to avoid progression to cirrhosis there. So let's bow our heads here. Dear God, we're just so thankful for your blessings to us. We're thankful for the gift of health and so much information about how it is that we can be healthy. Ask you to bless each one of us on our individual health journeys. Help us to, in every single choice that we make the best choice for our health, not only for our own benefit, but so that we can be examples to others and be beneficial to others throughout our lives. Thank you for Dr. Bouchon and his ministry to the folks who need gastroenterology assistance in our city, and ask you to bless he and his wife as they continue to serve our city medically. Go with us now and bring us back together next month in your name. Amen.
Thank you.
Thank you.
Thank you, Dr.
God bless
Bouchon.
all of you,
Good to
and
see
we
you
will look
all.
forward to seeing you a month from today on the third Monday of November. That will be our last Dinner with the Doctor for this calendar year. So watch your email for the announcements, and we will see you then.
Well, thanks.
Blessings.
Good night.
God bless you.